Hello folks and welcome. This voiceover PowerPoint will walk you through the expectations for this lesson and also dig into the anemias. Overall, our objectives for the lesson are listed here and cover a number of topics in both hematologic and immune disorders. As always, it's a lot to cover, so I've divided it up a bit and we're going to do some focused activity as well as quite a bit of background reading. Starting off with the hematologic disorders and focusing on anemia to start with, I'm going to ask you to look at the video series that is listed in your readings and replicated on the module folder on Blackboard to get you prepared to look at the rest of the cases in this voiceover PowerPoint. So you'll do that first, and then we'll take a look at evaluating anemia and look at some cases in this PowerPoint. You will go off and do some reading about chronic leukemias online and view some videos there in the Khan Academy. And then you will again do some reading on HIV in primary care with looking at the guidelines, as well as looking at the PrEP voiceover PowerPoint that I've prepared for you about one small aspect of HIV care. At the end of that module, this will not be available till the end of the week because I want to have the student presentation involved as well, which you are going to view for the hereditary forms of anemia. You will have an assignment, a self-assessment, which is a CBC matching assessment to be posted by the 10th. You will have 2 tries for this, and you can work on it together. It's going to count 25 points of your pretest score for the next lesson. It will be due on the 16th. Then you will go into Module 2 for autoimmune disorders. I'm going to ask you to do some readings again, and of course view a video, great video, nice short video on kind of the key features of lupus. And of course, I would recommend going back to the House MD clip, It's Never Lupus, because there are tons of clues in there about what could or could not be lupus and why. And at this point of the game, you might actually, as you listen to that, some of these things may make some sense after the reading. There is then an optional bonus point activity, a fun crossword puzzle that you can complete online and submit by October 16th for 1 bonus point added to your pretest and exam average for the semester. You are then asked to participate in an online discussion to take a stand about chronic Lyme and whether or not it is a persistent infection, an autoimmune response, or no such thing. In other words, there are people out there who don't think that it exists at all. This will count for 25 points of your pretest score for the upcoming October 18th lesson, and your final post in the discussion board is due October 16th. So let's dig right into anemia, and thanks to Noelle, who last semester walked us through evaluating for anemia. This is a nice comprehensive tool from the up-to-date resource telling us to take a look more carefully when we see anemia and think about what might be causing the cause of it, excuse me. So we're going to, first of all, of course, know that there's anemia, and we all know that anemia means low H&H, hemoglobin and hematocrit. Hemoglobin being about 1/3 of the hematocrit value. So kind of either or, but we look at both. And if we see the low H&H, we are going to then kind of next look at the MCV. Of course, we also look for abnormal RBCs, peripheral smear abnormalities that might take us down some other roads, but we really look first to see if they are microcytic, low MCV, normocytic, medium MCV, or macrocytic, high MCV. And then we walk ourselves down the chain in terms of that. I'm going to show you a couple of other more abbreviated algorithms that you may use as well. This is, as you can see, similar to the other one, but it's just one chunk of it where we have microcytosis. So microcytic anemias being fairly common, We go first for looking at whether or not they are what we call an iron deficiency anemia. We're looking for ferritin levels. And ferritin, there are several iron studies that can be done, and we will do them further down the road. But really, if we find that the ferritin is low, less than 15 nanograms per milliliter, we're pretty confident that we've got an iron deficiency anemia as long as the rest of the indices on the CBC look fairly normal. I will tell you right now, and you've heard this before in all of the online lectures, as well as talking to your preceptors in practice, that many cases are mixed. We don't always see a pure iron deficiency anemia. Keep in mind that iron deficiency doesn't just mean that the person doesn't eat enough iron, such as found in red meats or certain vegetable matter. This is possible. We see toddlers who get iron deficiency anemia because all they drink is milk and eat a few Cheerios now and again. So they become anemic because of lack of iron intake. But more commonly in adults, it's because the iron stores have been depleted because of some source of occult bleeding in the body. And that's why we want to dig into it and think about some other causes. So I'm going to pause there for a minute and show you another algorithm in a minute about iron deficiency anemia. But I wanted to emphasize that there is the microcytic anemia that's a little more common, and evaluating that uses that prior algorithm. There's also an app. It's not very comprehensive, but it just reminds us that if we have if we have a small MCV, that we check the ferritin, and if it's low and those two match up, we go iron deficiency. Otherwise, we're looking at normocytic or macrocytic anemias. There's also an online lab resource, which I've already introduced you to, which can help you sort through some of these things. So some people also want to know about reticulocytes, and if you view the video that I've put on the recommended readings, which is the deep digging into evaluating for anemia, that speaker talks a lot about reticulocyte counts. Keep in mind that reticulocytes are immature RBCs. They have a large MCV, so they can increase the overall MCV if there's a lot of them. So the lab will report a percent. You have to be careful not to pay any attention to the reference range. There has to be an index which ties it to the H&H. The key point about retic counts is that they reflect bone marrow response. They can't be interpreted in isolation. If you click into this resource here, it gives us a chance to consider the various possibilities. So here I've taken you to that page, and you can see, I'm going to let you also click to it yourself later on, but you can see that there is a variable use for the reticulocyte count. I sometimes see people using it to monitor responses to therapy, as well as to do diagnostics. I'm going to scroll down again, and it's ordered when we see the anemia sometimes. We're looking either at bone marrow function and response, or if we are thinking that the person has an iron deficiency, and we want to be sure that their bone marrow is responding. So you'll notice down below that it says they must be interpreted carefully in interpretation with other features. And you can take a look at this at your leisure, but it kind of walks you through the complexity of reticulocyte counts. So I'm going to take us back to this algorithm and walk us to the middle part where the ferritin isn't low. Again, this was quite simple over here. Down here we have a normal or high ferritin level. And so then we go further into checking iron levels, total iron binding capacity, and transferrin saturation. So if we see that the serum iron is decreased, we want to look on this side of the things, and we differentiate between increased binding capacity and decreased binding capacity. So we may still end up with a diagnosis of iron deficiency anemia. But if the TIBC is decreased, the transferrin SAT is decreased, we might see anemia of chronic disease. And I would like you to rename that in your brain as anemia of inflammation as well. So think of all of the things that can inflame the body in terms of chronic diseases, cancers, your various autoimmune diseases, all kinds of things, chronic failure, heart failure, and these people will end up with an anemia of chronic disease. And they're often very confusing and often mixed with iron deficiency anemia, so it gets very confusing. So if the serum iron level is normal, the TIBC is normal, and the transferrin SAT is normal, then we're going to look at the hemoglobin electrophoresis, which is, and we consider it earlier in children and young adults, because we're looking at some of the inheritable disorders, which are going to be discussed in the student presentation. And now going all the way back to the large algorithm earlier on, look all the way to the right and we see our large MCV, or large cell size. And what we're finding is that we are going to have a variety of other things that we're going to look for. Some of these other causes over here, we think about liver disease, hypothyroidism. Certain drugs can cause this. We may have a myelodysplastic disorder where we have some important things that are going to show up in smear. And then in the middle, again, a little more commonly, serum B12 and folate levels may be low, and we may have deficiencies in these two important nutrients, especially with folks in elders, folks who are nutritionally deficient because of diet, etc. I'm going to pause here, and there will be a part 2 to this video, which will take you through the cases from the field and explore them in terms of the parameters that we have just defined, and also the reading and viewing that you've done on the prior videos.